In this part of our lecture, we will study the fascinating and clinically significant injuries of the Lisfranc joint complex, also known as the tarsometatarsal joint. These injuries, although relatively uncommon, are notorious because they are frequently missed in the emergency department, and when overlooked, they lead to chronic pain, deformity, and long-term disability. Let us begin with some historical and anatomical context. The Lisfranc joint is named after Jacques Lisfranc, a French surgeon in Napoleon's army who described amputations through this region for soldiers with severe frostbite. The articulation involves the bases of the 5 metatarsals and their articulation with the 3 cuneiforms and the cuboid. The second metatarsal base is recessed between the medial and lateral cuneiforms, providing a natural keystone of stability to the midfoot arch. Stability is further reinforced by the Lisfranc ligament, a strong interosseous ligament running from the medial cuneiform to the base of the second metatarsal. Because of this unique anatomic configuration, the Lisfranc joint functions as the cornerstone of midfoot stability. Disruption here, whether by fracture or ligamentous tear, destabilizes the entire medial longitudinal arch. Mechanism of injury. Lisfranc injuries occur through 2 main mechanisms. The first is direct trauma, such as a heavy object falling on the midfoot or a crush injury. The second, more common mechanism is indirect trauma, often involving an axial load applied to a plantarflexed foot, combined with rotational or abduction forces. An example is when someone misses a step, placing weight onto a plantarflexed foot, or when the foot is trapped in a stirrup in equestrian accidents. Even seemingly trivial events can produce significant Lisfranc injuries if the right force vector is applied. Classification and patterns. Lisfranc injuries can be classified in different ways. The simplest and most clinically useful classification is by the direction of displacement. Isolated injuries involve displacement of only 1 or 2 metatarsals, while the others remain in place. Homolateral injuries involve all displacement of all metatarsals in the same direction, either laterally or dorsally. Divergent injuries are the most dramatic, with the first metatarsal displaced medially and the lesser metatarsals displaced laterally, essentially splitting the foot into 2 columns. On the lateral view, one may observe dorsolateral displacement of the metatarsals, which is often more evident than on the AP view. A classic radiographic clue to subtle Lisfranc injuries is the flex sign. This represents a small avulsion fragment at the base of the second metatarsal, indicating avulsion of the Lisfranc ligament. Recognizing the flex sign is essential because it represents instability even in the absence of gross displacement. Clinical presentation. Patients typically present with midfoot pain, swelling, inability to bear weight, and often plantar ecchymosis, bruising along the sole of the foot, which is highly suggestive of Lisfranc injury. Because these injuries are often ligamentous rather than purely bony, they may not be obvious on initial plain radiographs. A careful vascular exam is essential, as compartment syndrome of the foot can occur, particularly in high-energy crush injuries. Imaging. Standard radiographs include AP, lateral, and oblique views. On the AP view, one should carefully assess alignment between the medial margin of the second metatarsal base and the medial border of the middle cuneiform. A displacement of more than 2 millimeters is abnormal and indicates Lisfranc injury. On the oblique view, the alignment between the lateral border of the third metatarsal and the lateral border of the lateral cuneiform should be checked. Stress views or weight-bearing radiographs can unmask subtle dystasis. When radiographs are inconclusive but clinical suspicion remains high, CT scans can be extremely helpful in identifying fracture lines, displacement, and subtle incongruities. MRI may be useful in demonstrating purely ligamentous injuries, but it is not usually necessary in the acute setting. Treatment. Treatment depends on the degree of displacement. Non-displaced injuries, without widening, may be treated non-operatively with casting and non-weight bearing for 6 to 8 weeks. However, if there is displacement of more than 2 millimeters between the base of the first and second metatarsals, the injury is considered unstable and requires surgical intervention. Minimally displaced injuries may sometimes be stabilized with closed reduction and percutaneous pinning. Displaced injuries, however, almost always require open reduction and internal fixation using screws or Kirschner wires to stabilize the first and second metatarsals to the cuneiforms. In some cases, especially in high-energy injuries with severe comminution, primary arthrodesis of the medial column may be considered as an alternative to fixation. Prognosis and complications. Despite optimal treatment, Lisfranc injuries have a guarded prognosis. Chronic pain, stiffness, and post-traumatic arthritis of the midfoot are common. Malreduction or delayed diagnosis often leads to collapse of the medial longitudinal arch, producing a flat foot deformity. For this reason, early recognition and accurate anatomical reduction are critical to achieving the best possible outcome. Summary. To summarize, the Lisfranc fracture dislocation is an injury of the tarsometatarsal joint, most commonly due to axial load on a plantarflexed foot. The second metatarsal base and the Lisfranc ligament are key stabilizing structures. Injuries may be isolated, homolateral, or divergent, and the flex sign is a key radiographic clue. Treatment depends on displacement. Non-displaced injuries may be casted, while displaced injuries require surgical fixation or arthrodesis. Ultimately, the lesson of the Lisfranc injury is that a small misdiagnosis can have lifelong consequences for the patient. This is why orthopedic surgeons are trained to have a high index of suspicion for Lisfranc injuries whenever there is midfoot pain after trauma, even when the initial X-rays appear normal.